afternoon, everyone. So thrilled that you're joining us on this rainy day. We're thrilled to have Dr. Martin back to give us another segment of our 2021 HTRC education series focused on telehealth billing, coding, and policy. Today's topic is going to focus on remote patient monitoring. Just a few minutes before we get rolling with our Heartland Telehealth Resource Center series. Just a heads up that the session's being recorded and we'll share it with you afterwards. Your microphones have been muted, but we really do want to encourage keeping your cameras on and also sharing input in the text. In the chat so that we can hear your questions. We'd also love if you can introduce yourself in the chat. I know several folks have already done that, so thank you. It's a-okay also to eat. We know it's the lunch hour, so we want to see your face and have your input, but we also totally encourage you to move forward with your lunch or other things in the busy afternoon. Just a heads up that your completion certificates will be emailed. It's important to sign on with your first and last name so that we're able to identify you and send you the certificates. So with no further ado, I know we have a lot of great information to cover today. For some of the new folks on the call, let me introduce Dr. Marting. Dr. Rochelle Marting is a local attorney who is also a registered health information administrator and certified medical coder. Her extensive practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information technology, and management and regulatory compliance. So thanks so much for joining. We look forward to your presentation.
Thank you so much. I'm really excited for this topic today. And I appreciate everybody contributing to the chat so I can see where you're coming from. That's also really helpful for me as I go through the information. And the topic of remote patient monitoring is particularly interesting to me because it's a relatively new service that Medicare began covering just a few years ago. And kind of like we've seen with telehealth in the last 12 months, 18 months now, through kind of the public health emergency, remote patient monitoring has really exploded even before the public health emergency. And then during the public health emergency, there's been some changes to remote patient monitoring that have really become an increased interest to healthcare providers. And so I'm going to talk to you about what I mean when I say remote patient monitoring and kind of the evolution of coverage for remote patient monitoring services, some coding and billing aspects of remote patient monitoring. And one thing that I'm really excited to talk to you about today is something called remote therapeutic monitoring. And unless you happen to have dug through the 1,700-page Medicare physician fee schedule proposed rule for next year, you may not have heard the term remote therapeutic monitoring yet. It's something that goes along right hand in hand with remote patient monitoring. That's something that we can expect to be covered beginning January 1st of 2022, potentially, if these proposed rules get finalized. And we're going to have another session in August on the full Medicare proposed fee schedule and what that means in terms of coding and billing and telehealth. So make sure you join that session because, as you can imagine, there's a lot in there that has to do with telehealth services and billing. And I'll touch on remote therapeutic monitoring again in that session, but you'll get a preview that is only 3 days hot off the press on this potentially new service that we have to look forward to. So with that, I'll dive right in to what you will see abbreviated often as RPM, remote patient monitoring, but probably more precisely, remote physiologic monitoring. And I'm going to use that term physiologic monitoring because that becomes a really important distinction between these services and codes that I'm going to talk about first, and then the remote therapeutic monitoring that are on the horizon potentially for coverage in 2022. So the physiologic piece becomes really important. Now, the way that these services are defined is that they're the collection of physiologic data. In the code book, if you were to look at the codes that we use for these services, physiologic data are things like EKGs, blood pressure, glucose monitoring, oxygen saturation. So physiologic, I guess I said blood pressure, temperature is another one that we're seeing, weight. So data from the patient. And the way that this information is collected is on a device that can measure those parameters and then digitally transmit it to a healthcare provider. So there's kind of two important pieces to RPM, remote physiologic monitoring, that we're going to distinguish from RTM that we'll talk about in just a little bit. And the key piece is what type of data is collected: objective physiologic measurements for RPM, and it's digitally or automatically transmitted to the provider. Now, these are not conversations with the patient. It's not done by a phone call. It's not done by audio visual telecommunications. So it is not telehealth in the sense, in the way that that term is defined for Medicare. But that's almost a good thing, because that means a lot of the restrictions that we have in a normal environment for telehealth, in terms of the originating site where the patient is located, rural geographic areas, and all of those other restrictions do not apply to remote physiologic monitoring. That means we can do it in metropolitan areas. We can provide this to patients in their home and any other setting. So that's a real plus. These are categorized under the care management category of services for Medicare. And I'll talk about what that means in just a little bit. There's no originating site restrictions, no audiovisual equipment. The codes that we have right now fall within the evaluation and management section of the CPT codebook. So one of the implications of that is that it restricts the healthcare professionals who can bill for these services to healthcare professionals whose scope of practice and licensure allow them to bill for evaluation and management services. So it is kind of one caveat or restriction or limitation, and that's going to be a difference between some of these codes and then what we see with RTM that we'll talk about in just a little bit. However, when we look at these codes, a lot of the actual work and monitoring that's being done is not done by the actual physician or qualified healthcare professional. It's clinical staff time to do the monitoring, and then we may have a physician or qualified healthcare professional who's using that data to affect the care and the treatment of the patient. Okay, so I mentioned that remote physiologic monitoring, the codes that we use for that are evaluation and management codes, and they're classified as care management services. And in terms of the Medicare benefit, right? So telehealth is a type of benefit. And care management, like transitional care management, chronic care management, and then remote physiologic monitoring, all fall under kind of this umbrella term of care management services for Medicare. And with care management services, there are a few kind of umbrella or default rules and requirements that we need to keep in mind. One of those is that we have to have patient consent before we provide this service and bill for it. And really, the fact that we can bill for it and be paid for it, and that there's patient financial responsibility, deductible and coinsurance, is one of the main reasons that Medicare requires that we get the patient's consent. Now, that does not have to be a formal, one-page written consent document. That can be as simple as, Rochelle, we offer this service. Would you like to have this monitoring service? And Rochelle says yes, but the key is we document it. If it's not a form that we're going to scan into or incorporate into the chart somehow, we're still documenting somewhere, somehow, that the patient has consented to receive the service and understands that there's a financial responsibility for it. Generally, that consent, we want that to happen at or before the time of service, right? So before we begin actually monitoring the patient, we want to have that consent, receive that consent, and document that consent. The other thing that is important with the care management category is that the level and the type of supervision that is required of the physician or the qualified healthcare professional that's kind of responsible for the care and management of the patient is um, a lower or more relaxed level of supervision than is required for many other services. For a lot of services, we have to have direct supervision. And Medicare defines direct supervision as the healthcare professional being in the office setting, in the office suite, and immediately available to provide assistance when needed. Well, that doesn't make sense for remote monitoring services where the patient is not in the office suite where the monitoring is being provided, and sometimes the nurse or the clinical staff who's helping monitor these services may also not be in the office suite where the healthcare professional is located. General supervision is more relaxed. It means that the professional who's billing for the service still is responsible for the overall care and management of the patient, but there's no physical presence requirement to be in the office suite with the clinical staff doing the monitoring or in the office suite where a patient is located. That does a couple really key things for us in terms of remote patient monitoring. And one of the biggest benefits of that I have seen is that it allows you to use remote clinical staff. So in many cases, smaller practices, smaller groups may be pooling together a clinical resource among different practice locations. And that's okay because a nurse in one clinic doesn't have to be physically located in the same office suite as a provider in another clinic, or using third-party services where that individual may not even be located in the same state when the service is provided, with an asterisk that they still need to be licensed in the state where the patient is located in most instances. But it does give us some flexibility on where we're doing the monitoring from. So general supervision and consent are two of the key components of this being a care management service. Now, these started around, I want to say 2017. And it started with this CPT code 99091, collection and interpretation of physiologic data. So objective, quantifiable data like blood pressure, weight, temperature, pulse oximetry, and those types of measurements. And that data is digitally stored and it's digitally transmitted to the healthcare provider. And I have in bold here, physician or other qualified healthcare professional, and required a minimum of 30 minutes of time in each 30 days. So there are a couple of things that are important with this code description, and probably the biggest qualification and restriction of this code was the piece about this being to a physician or other qualified healthcare professional. That meant that this service really was a physician, nurse practitioner, or physician assistant service. And the usefulness of that was fairly limited because in practice, it really wasn't the physician or the nurse practitioner or the physician assistant doing the monitoring, looking at the blood pressure measurements, looking at weight, looking at the patient's pulse oximetry and doing stuff with that data. That was really more suitable to individual professionals with other scopes of practice, like registered nurses, to monitor that data within certain parameters, to know that Rochelle needs to be monitoring her blood pressure every morning and we want it to stay within these bounds. And that wasn't something that necessarily required a physician, nurse practitioner, or a PA to perform. So that was somewhat restricting with this original code. And then I have the time measurements bolded because we're going to see a difference between this code and some of the newer codes that we have available. The other piece of this is the minimum of 30 minutes. So I've mentioned this a few times in our educational sessions that CPT has this kind of funny rule that generally when a code has an increment of time, like 30 minutes, there's something called a midpoint rule, that when the code says 30 minutes, it doesn't really mean 30 minutes. Sometimes that means you have to cross the midpoint. In other words, you have to have a minimum of 16 minutes to report a code that says 30 minutes. It's kind of funny. I don't know why they don't just put the minimum time requirement unless the code specifies otherwise. And this code 99091 is an example of that, where it says a minimum of 30 minutes. That midpoint rule doesn't apply. The 30 minutes is a minimum threshold that you would have to meet in a 30-day period to be able to report this code, meaning 30 minutes of time spent monitoring the patient. The other piece of this is 30 days. CPT is kind of funny too, in the way that it measures time as either 24-hour periods, which could mean noon on one day to noon the next day, or calendar days, or a calendar month versus a running 30-day period. So this code was designed to capture any running 30-day period, meaning today's the middle of July. It could run from the middle of July to the middle of August. And as long as you have 30 minutes of time monitoring the patient in that 30-day period, you could report this code. That's not the way all of the monitoring codes work, though. We have to have patient consent. I mentioned that again because there is cost sharing. Even though providers can get paid for it, the patient's deductible and coinsurance for Medicare continue to apply. Another, not challenge, but something to be aware of, because this is a care management service, Medicare requires that care management services that happen that are not necessarily face-to-face services, like this, where we're monitoring the patient's data, not while they're in the office or in the facility, but while they're at home in between visits, is that the patient needs to be established. They need to have had a face-to-face visit within the previous calendar year before we could provide these remote physiologic monitoring services. A drawback, as I mentioned, to this initial service was that it didn't take into account clinical staff time. That 30 minutes of time had to be provided by the physician or other qualified healthcare professional, someone who's eligible to provide and bill for evaluation and management services. And it didn't pay for the equipment. So the blood pressure cuff, the scale, the pulse oximeter that we give the patient that is capable of digitally transmitting the readings to the provider, there was no payment for that available previously. So that was a limitation of the way that that code was structured. Some good things about that code is that there wasn't a requirement for a provider order. There were no restrictions on any particular type of device that we used, other than it had to have the capability to digitally transmit information. So this was kind of the beginning of remote physiologic monitoring and Medicare covering that, but it really wasn't widely used. It didn't get a lot of attention because of some of those restrictions. Here are some other codes that are available. I think I've got this slide out of order here, so I can come back to it in just a moment. There are other codes that are available to monitor patients' physiologic data. So this might be something like continuous EKG monitoring, continuous glucose monitoring. So if I go back one slide to 99091, if you were to look at this code in the code book, it's kind of funny because even though it uses EKGs and glucose monitoring as an example, there's also an instruction that says, don't use this code if there's another more specific monitoring code available. So if you were doing EKG monitoring or glucose monitoring and it met the requirements of some of these other already existing codes, you would report these more specific codes first if you met the criteria and not 99091. But if you were doing EKG monitoring or blood glucose monitoring and it didn't meet the criteria for these more specific codes, then 99091 was a possibility, assuming you all met all other requirements of that code. So fast forward to about 2018, 2019, in that time frame, Medicare introduced, well, I should say, in CPT, several new codes were introduced, and Medicare said that they would cover new remote physiologic monitoring codes. And these were the ones that really started to get attention in the industry. There was a lot of interest and excitement about these codes, but initially some significant limitations that we have slowly been kind of working the kinks out of these codes over the years through rulemaking. And there's a series of 3 codes or services. So this starts out with an initial monthly service where we get the patient the equipment. We teach them how to use the equipment, get them all set up, provide the equipment. We get paid for the equipment, which is a huge advantage over what we had in place previously. And then there is a service to a code where we can get paid each month for the monitoring that we do for that patient over a period of time until the patient achieves their monitoring objectives under the treatment plan, and that would conclude the monitoring episode of care. And that's going to become significant in terms of when and how we can report those initial setup codes. So let me kind of walk through these 3 codes. 99453. Okay, so this is a code that would only be reported during the initial month of an episode of care. And an episode of care is any particular parameters that we're monitoring until the goals of treatment are accomplished when the episode is concluded. And 99453 is only reported once in an episode of care for remote physiologic monitoring. So weight, blood pressure, pulse ox, respiratory rate, any of those physiologic parameters. Now, notice these are just examples. So those are common ones. It could be, I don't see temperature listed as an example. That's a really common one that we see for post-op monitoring to look for signs of infection. This is for the initial setup of the patient, education and use of the equipment. So how do you take your blood pressure? How do you use the blood pressure cuff? How do you use the pulse oximeter? How do you use the scale and setup of the technology so that it will transmit that data to the healthcare provider? 99454 is another code that we can use for the remote monitoring. Again, it lists out the parameters. The initial service, let me get my cursor over here, initial service. Now, this is the code for the equipment. So 453, that's the work and the time to set it up, to educate the patient on how to use it. But 454 gives us payment for the actual device. One of the limitations here is that there's one payment rate for 99454, regardless of what device you're giving, how much it costs you, or how many devices you're giving the patient. So it is some payment for the device, but in some instances, it may not cover your supply costs in all instances. That's something you want to be aware of. So it's the initial device or supply, okay? And you'll see the parenthesis S. That parenthesis S means we get to report these codes once, regardless of how many parameters we're monitoring. If you're monitoring blood pressure, great. Educating the patient on how to use the cuff, 99453. If you're doing all of these, weight, blood pressure, pulse ox, respiratory rate, it's still one code for the education and setup, whether we're doing one or more physiologic parameters. And then 454, that's going to be, as you can see, each 30 days. Okay, so that's the supply cost each 30 days. But the code that really gets a lot of attention is 99457, because this is really the treatment, management, and monitoring of the patient. You'll see the 20 minutes of time. Okay, so that's different than the original code that required 30 minutes. 20 minutes of time. And then in gray here, you'll also see clinical staff time is included. So clinical staff is defined in the code book as individuals who are not able to bill independently for their service. So a physician is not clinical staff, nurse practitioners, not clinical staff. These would be like registered nurses, LPNs, CNAs, who still within their scope of practice can monitor this data. Excuse me. Clinical staff or physician or qualified healthcare professional time in a calendar month. So if I go back 2 slides, remember that said a running 30-day period, they changed that structure with the new codes to be a calendar month. So if we were to start a patient on this service on July 29th, we may not meet 20 minutes of monitoring services in that calendar month. We could not report the code. We would have to wait till the next month. These services require at least one interactive communication with the patient in the calendar month, that like a phone call with the patient saying, hey, Rochelle, you're missing you're taking your blood pressure, or you're doing a great job. How are you feeling? Are you having any symptoms? Checking in with the patient. That's one of the activities that can comprise that 20 minutes of time, but also all of the other monitoring and treatment management activities for the patient also count towards the 20 minutes. With that, I want
Michelle,
to, yes.
I hate to interrupt you, but we have a question in the chat that I wanted to make sure we got to
Yeah,
before
let's
we
do it.
moved along. Okay, so it says for setup and training with the patient, does that need to be a healthcare professional such as an RN, say versus a technical support team to be reimbursed?
Okay, so great question. With 99453, where we're doing the initial setup and the education with the patient, that code and the definition of that code does not prescribe who must provide that service. Someone who's qualified and trained on the equipment can do it. When this is billed, it's going to be billed under the name of a supervising healthcare professional, right? The professional that is providing the general supervision for the service. So 99453 and 454 and 457 are generally done incident to the physician or qualified healthcare professional's service, which makes sense because as a care management service, there has to be at least one face-to-face visit in the preceding calendar year before we could even deliver this. So it's the professional identifying that the services are needed. And then there are other staff, which could be clinical, but not necessarily clinical. Like maybe an IT person would be better to help set up the equipment. I don't mean strictly IT, but someone with technical expertise in the practice could actually provide 99453, the setup and the education incident to the provider's instruction. So it doesn't have to be someone with a clinical licensure necessarily doing that. Great question. I will say though, for 99457, that does have to be clinical staff who's doing the monitoring services. Thank you for that question, because who provides what can be really important. And the last piece of this, that particularly with 99457, with 99091, where we have minimum time requirements, the thing I want you to be thinking about in delivering these services and documenting what you're doing is that means all of the time you're spending throughout the month needs to be recorded. This is not necessarily 20 continuous minutes. It is often happening, maybe at the end of the week, you're looking at values that come in, or there are third-party companies that kind of have dashboards, and we have patient-specific parameters. We want Rochelle's blood pressure to be less than, I don't know, say 130/80. And if it's 135, there might be a red flag or something that calls to the attention of a clinical staff person, and they go in and they're looking at my data and looking at the time of day, looking at different things to look at my values. That time we want captured and we want documented, because we need to support that we've provided at least 20 minutes of monitoring. We also have to document when there's been that interactive communication. We have to document that there's been a phone call with the patient to show that we've met at least one interactive communication with the patient during the calendar month.
Rochelle, I just got another question that was sent to me.
Perfect.
Do you have to, do they have to be at the home, or can education be provided via telehealth?
Okay, perfect. And it's not specified in the service. Yep. So we have to think then about the place of service that we're using. Let me make a note of that. If it is not done as a face-to-face service, that would impact the place of service code that we're using on the claim form. And I'm going to make a note of that to go back and look at the the telehealth service list and to see if this is on the list as a category 1 or 2, meaning if it's something that could permanently be provided via telehealth, or if it's temporary. And I can get back to you on how that would work if you were doing it as like an audio visual type service where you're giving the setup and the training. Prior to COVID, the patient was often getting the equipment in a face-to-face setting, but now it's very possible for that to get shipped to the patient. And we have the education training or setup that's done via a different medium. So I'll give you some more information and citations on that as well, but the code itself does not require that be done face-to-face. Great
Perfect.
question.
Thank you so much.
Yeah, and I can send that out to you to send out and share after the session as well. All right, so when we're talking about remote physiologic monitoring, to kind of compare and contrast what we had in place before and these relatively new services, is that as I mentioned with 99091, one benefit is there was really no definition or restrictions on what type of device you used. There are devices you could buy at CVS that are technically capable of digitally transmitting information. And under 99091, that could have been allowed. Under 99457 and all of the other, the newer remote physiologic monitoring services where we have initial setup, the device, and then the monthly treatment management, the rules require that you have a device that meets the definition of a medical device under the FDA. But Medicare has given very clear guidance that doesn't mean it has to be FDA cleared. It just has to meet the definition of a medical device. So that's really important. And there's tons of devices on the market now that have come out in the last couple of years that would meet the definition of medical devices. The previous code, maybe because it had to be delivered by a physician or qualified healthcare professional, didn't require an order, whereas the newer services, because it can involve clinical staff time, they do require an order from a physician or qualified healthcare professional. It makes sense because we've got a provider that has to initiate the service as being a care management service, but we want an order for the service. They do not require a prescription. And this to me has been a little bit confusing. Medicare's never really distinguished what they mean by an order requirement, but not a prescription requirement. And the best way I've been able to kind of separate those concepts in my head is that to me, the order is for the service. We want Rochelle to remotely monitor her blood pressure. I'm ordering the service, but a prescription I think of as in the context of DME and other devices, we don't have to have a prescription for the device. Kind of confusing, kind of splitting hairs, but Medicare's been very clear: a prescription's not required, but an order for the service is. Consent is required for both because there's cost sharing involved. Now, the face-to-face exam, there's kind of a question mark with 99457, and I'll get the clarification on that first code, because some of these services do not necessarily take place in the office suite as a face-to-face service. And there was some question on that, particularly when the codes were initially created. The reporting period is also different. So remember with that first code, it said a running 30-day period. And with the new service, it goes by a calendar month instead of running 30 days, which is, I think, very confusing. I'm not sure why they distinguished it that way. With the new codes, that 30-day, that calendar month is subject to the midpoint time rule. So when they say a calendar month, they actually mean 16 days of monitoring within a single calendar month. Don't know why they make this complicated. Why can't they just say what they mean? But that's something that's important for us to know. I'll also mention that during the public health emergency, if the remote physiologic monitoring is being done for COVID-related symptoms. So temperature, respiratory rate, pulse oximetry to monitor the progression or improvement of COVID-related symptoms. That time frame has been temporarily decreased to 2 days, so it can be fewer than 16 days during the public health emergency. Afterwards, it'll go back to a minimum of 16. The provider time is decreased from 30 to 20 minutes. And in addition to physicians, nurse practitioners, and PAs, it could be clinical staff who are doing the monitoring service for the patient, who are providing that interactive communication, the phone call or telehealth visit. I should mention as well that interactive communication, the phone call, the telehealth service, that's paid for as part of this code. That is not a separately billable and payable service, unless you're doing completely distinct and separate things during that telehealth visit. But your documentation would need to be clear about that distinction to support billing, like an office visit or an audio only phone call, at the same time as the interactive communication for remote physiologic monitoring. So then let's take a look at kind of what's captured. What are you getting paid for each of these codes? The setup for the patient, the education for the patient, that's a technical service. So as is the equipment, the payment for the equipment itself. But then 457, the monthly treatment management service, that's a professional service, as is 99091 for the monitoring. 99453, the setup and the education can only be billed once per patient per episode of monitoring. Okay. And the episode ends when the goals of monitoring have been achieved. And it could potentially restart again if we have new goals, new treatment goals, different parameters that we want to monitor under a different treatment plan. Then 99453 could be used again to provide a new device to educate and set up the patient during that new episode. What I think is particularly confusing about the codes that we can report monthly, there's a code we can report monthly for the equipment, the technical piece of this, and it's every 30 days, a running 30-day period, but the treatment management is again the calendar month. So why in the same package of services we have different time measurements? I'll never know. I tend to think it's for job security for folks like us who are trying to do the coding and billing. But keep that in mind that you could give the patient the device from July 15th to August 15th. And you can have in that running 30-day period, you could report 99454, but you couldn't report 99457 until you have 20 minutes of monitoring with an interactive communication within a single calendar month. Kind of makes your head spin. Okay, we've talked about the time requirement, interaction with the patient. So giving the equipment, the monthly charge for the equipment doesn't require an interaction with the patient, but the education to the patient does, as does the monthly treatment management service. It's built right into the code that we have interaction with the patient. Okay, so I want to kind of talk through some of the evolution of the coverage rules for this service. When it was first covered in 2019, a huge limitation was that it could not be delivered incident to a physician's professional service, which meant that essentially that the biggest benefit that this could be provided by clinical staff was like negated, because incident to means if provider establishes the plan of care and your clinical staff carry it out. Like, Rochelle, we want you to have your blood pressure within these parameters. So come in for a monthly blood pressure check, and you're going to have a visit with the nurse during those visits, not necessarily the physician. That's an incident to service. That was an oversight. There was a technical correction a few months later saying, yes, this can be done incident to, it can be provided by clinical staff, but the level of supervision was not clarified. And the default for incident to services is direct supervision. So that clinical staff person had to be in the office suite where the supervising provider was physically located. That was a huge restriction because a lot of practices didn't have a clinical person dedicated to remote patient monitoring while they're kind of building out this service. It also prevented us from going and using third-party companies, that can do the service nationwide, because their clinical person was not on site in the office suite where the provider was located. So then in 2020, recognizing that, we had a development where Medicare classified these as care management services, where everything in that category is allowed to have general supervision. And that really opened the door to allow these services to be provided by third parties, to allow practices to pool resources and have a clinical staff person to support them. Then we had some developments during the public health emergency, where right now, and limited to the public health emergency, you can do remote patient monitoring for new or established patients. Outside of the public health emergency, it has to be an established patient, which is going to happen anyways, because for care management services, you generally have to have a face-to-face visit within the preceding 12 months. So you're going to have an established patient anyways. Now, if I were to call a brand new primary care office that I've never been to with, say, respiratory symptoms, and they want to send me a pulse oximeter and a digital thermometer to monitor me for COVID symptoms, they could do that with me as a new patient and bill for remote physiologic monitoring and be paid for it. They also clarified during the public health emergency that this can be for acute or chronic conditions. So again, recognizing that this could be for COVID-related symptoms, something acute and short-term, versus what it generally would be used for long-term chronic conditions. We also have the flexibility right now, only during the public health emergency, to be able to bill for these when there's fewer than 16 days. There are two situations where that really arose, and one was monitoring the patient for COVID-related symptoms, where generally we didn't have to monitor the patient for 16 days. Kind of, in most cases, hopefully would run its course in that time frame and the patient was improving. It was also used for post-op monitoring. So rather than having the patient come back in and increase exposure in person, we could monitor the patient post-operatively and monitor their temperature and other measurements to look for signs of infection and other potential complications that may occur after a procedure. One restriction that we have right now within and outside of the PHE is that it's not covered as a separate payment for FQHCs and RHCs. So that is, from my perspective, a significant limitation of the remote patient monitoring as we have currently. So now I want to give you a preview for something that I'm really excited about, that it was addressed just in 1 or 2 paragraphs in the 1,700 pages of the proposed rule for 2022. But remote therapeutic monitoring is going to continue to open the door for a lot of non-face-to-face interactions with patients and taking care of them kind of in the interim and getting, I think, better data on how patients are doing outside of really objective, strict physiologic parameters. So I talked with a couple of companies in the last few years who had developed really cool tools, assessment instruments for things like range of motion, which could be great for orthopedic post-op recovery, for physical therapy, ALS, monitoring functional status. I can see significant benefit in the mental health arena, monitoring mood, kind of that PHQ-2 or PHQ-9 assessment, where it's subjective, right? It's not a device taking that physiologic measurement and transmitting it, but it's the patient inputting data that still gets transmitted, but it's more subjective data for remote therapeutic monitoring, which previously was fairly limited in its coverage, but now we're seeing kind of subjective, non-face-to-face monitoring counterparts to the remote physiologic monitoring that we've been seeing coverage for in the last several years. So this started with the American Medical Association and CPT creating some new codes for therapeutic monitoring. Okay, so these are looking at things like your musculoskeletal system, so functional status, activities of daily living, respiratory status, adherence to therapy. So physical therapists, for example, could be a really good example of that. Therapy response, pain scales. I can see uses for that in, drug management. So many options with this, and related to signs, symptoms, and functions. So again, much more subjective data. It's a device generated data, so I can see apps and those types of equipment or programs to collect the data that get transmitted and tell us a little bit more about the patient's status in between visits. Those of you who maybe provide these types of services or monitoring face-to-face when the patient comes in every few months or 6 weeks or however often it is, and you say, how are you doing, or how did you feel after these therapy, and it's like what's on their mind in that moment. But this gives us a much more longitudinal view of how the patient was doing over a period of time, and the patient says, oh, I did great, but you can see their responses that maybe were not so favorable over time. And without the patient being face-to-face, we may get some more honest responses too on how they're feeling in that exact moment. They were created in 2020. They've been valued. Medicare in the proposed fee schedule for 2022 approved the values that the American Medical Association established. So these appear to be services that Medicare is going to consider for coverage. The structure of these codes looks very similar to the remote physiologic monitoring. A huge difference, a big benefit though, is that remember RPM and the predecessor code 99091, they fall within the evaluation and management section of the code book. So they are restricted to being used and billed by healthcare professionals who are eligible to bill E&M. Therapists are a big example of professionals who don't benefit from that. But these codes, remote therapeutic monitoring, they will fall under a section at the end of the code book, the medicine section, where we don't have that same restriction. So the intent and design behind these is that they could be eligible to be reported by types of professionals who may not be eligible to report E&M services. They can still be reported by physicians, nurse practitioners, and qualified healthcare professionals. We're looking at we could have self-reported data, which is a huge benefit over this. Self-reported information is explicitly not covered on remote physiologic monitoring. And then Christy,
Michelle,
I see the question. Yeah.
All right, do you want to go ahead and take it, or would you like me to read it out loud?
Yeah, so this is initial evaluation and management visits are on the approved list of telehealth. So can you establish the first qualifying that? Yes, so that's a great question. That initial face-to-face visit requirement that we have with care management services, where initial E&M codes are on the telehealth list, that initial E&M can be done as a telehealth service to establish the plan of care for the patient, where RPM or RTM are done incident to that initial visit with the physician or qualified healthcare professional. Great question. Okay, so we don't have a lot of information from Medicare on these codes yet. So when I saw this in the proposed fee schedule, got really excited about it. I went back to all the historical documents from the American Medical Association to see what they're saying about it and what their intent is. And in those documents, the Resource Utilization Committee and the CPT Editorial Committee that was developing these codes envisioned that these were primarily provided by nurses, physical therapists. That's how they were valued. So while they're available, a physician could provide the therapeutic monitoring. Again, it's designed for other professionals to be doing the monitoring service work under the general supervision of other professionals. Medicare to be perfectly honest, I've dug into the description of these codes in this very brief statement that Medicare made that I'm not quite following Medicare's logic yet. But Medicare said, as these are constructed, the concept of incident to billing for Medicare purposes applies, and Medicare sees that as a restriction because under its incident to billing rules, the professional who ends up billing for the service and who establishes that initial plan of care that the monitoring is incident to only allows certain professionals to have that initial qualifying visit. And physical therapists and those types of professionals are not on that list. Medicare says we recognize that as a limitation because we think these are intended to, and we want them, I get the impression, to be provided by therapists and other professionals, and Medicare is seeking comment on how to rectify that limitation. So it's possible in the final rule that we typically see in about mid-October that we see a kind of correction or some mechanism to adjust that, so physical therapists and other therapists can still provide RTM, notwithstanding some of the limitations that are in the code description. Another issue with these services that while there's a benefit to them being in the medicine section in terms of who can provide them and who can bill for them, as medicine codes, because they're not evaluation and management codes, they don't fall under the care management category, that benefit category that universally allows for general supervision. And it is only through the care management category that we don't have to have a person in the office suite and immediately available. So Medicare's trying to, in their heads, trying to work through, how do we recognize direct supervision doesn't work? So what is the mechanism that we allow the broader general supervision to apply to these codes as well? So I expect some kind of explanation or maybe a delay in allowing general supervision to come out in the final rule. But it's good, I think, that Medicare is recognizing this up front, where with RPM, it took 3 years to kind of work through the kinks on those services. If you have thoughts on how to rectify some of those situations, Medicare is seeking comment on that. And if it's something you or your practice would benefit in providing, I would encourage you to find the proposed rule and submit comments on being in favor of this service to encourage Medicare to move in this direction. Because I certainly can see a lot of benefit for that subjective data collection to be covered without taking the time and the resources for an in-person or telehealth, true telehealth type service. So this is what the codes look like, or would look like for remote therapeutic monitoring. The final code value hasn't been established. We would see that in October or November when the code set comes out. But it's structured very similarly to RPM in that we have codes for physician or other qualified healthcare professional. We have calendar month. We have at least one interactive communication, and then we have time-based codes. So the first 20 minutes, we have each additional 20 minutes in a calendar month. What we don't have is clarification yet on whether that 20 minutes is subject to that funny midpoint rule where 11 minutes would actually count, or if that's a minimum threshold. So that's kind of a question mark or guidance that I would expect to see if this service ends up being covered. And over the next few years, I assume we'll get more clarification on it. Then we have remote therapeutic monitoring. So this is the equivalent to 99453, that initial setup and patient education. But in this case, it would be getting them set up and educated on the app, the program that they're going to input their subjective data on, and how to do that. Maybe education on the scale or the spectrum. You know, this is what a 1 means. This is what a 2 means, and so on. Then we have the supply, the device, just like we have with 99454, that can be reported each 30 days, not a calendar month, 30-day period. And then the code for the ongoing monthly monitoring. Now, this is a little funky because the monthly monitoring for physiologic data is a calendar month, even though the device is a 30-day period. Here, they still do a 30-day period for the device, but then I see each 30 days, not a calendar month, running 30 days for the monthly monitoring of the information that the patient's submitting. So again, I have no explanation for why they use these different time frames, just something that we want to be aware of and how we kind of develop flow sheets and things like that. Whenever we have these time requirements, the first 20 minutes, each 30 days, we want to make sure we're documenting to support that we've provided that 20 minutes, or depending on what the guidance says, that may end up being a minimum of 11 minutes in a 30-day period in the first month. So a couple of other things that I wanted to point out is these are the codes that have been getting a lot of national attention over the last few years, and people are getting really excited about. But there are other codes and services that have been in CPT that have been covered for a long time that really haven't gotten a lot of attention, but they still represent remote monitoring type services. So I just wanted to point these out, that they're in the book, they're available. Take a look at them if you're providing any of these services, or if they may be a benefit to your practice. So pediatric apnea monitoring through a device. You see download of data, review and interpretation, looks a whole lot like these other services. And remember that when there's a more specific monitoring code available, use the more specific code than the new ones that we have available to us. Monitoring of a wireless pulmonary artery pressure sensor, 30 days, weekly downloads, looks and feels very similar, except it's very specific to a pulmonary artery pressure device. Continuous glucose monitoring. We saw this a few slides ago, right? So that's the monitoring. We have a code for the sensor placement, the hookup. That's very similar to the device setup and education. We have the equipment, and then we have the analysis, interpretation, and report. Very similar to the structure we have for RPM and RTM. So with that, stay tuned for some of the sessions coming up where we really dig into the Medicare proposed physician fee schedule. By that time, we may have some professional societies submitting guidance or questions or comments on RTM services that I may have a little bit more insight on where Medicare may be headed October or maybe early November for coverage in 2022. I have my note, Christy, to look into that face-to-face visit at the beginning of the remote patient physiologic monitoring episode, and can that be provided via telehealth, and are there any limitations after the public health emergency that I'll get to you. And of course, if you have any questions afterwards, feel free to email those to the HTRC email address as well. Happy to answer those and dig through all the guidance that's been changing on these over the last several years and let you know what's in place now.
Thanks for that wealth of information, Rochelle. I know we're close to the hour, so I really do encourage folks to send their questions to the HTRC, and we can include some of that in the follow-up email that folks will get with both the recording and the responses to questions. We also hope you'll join us on Friday, July 23rd, when Rochelle will talk with us about mental and behavioral health specific services via telehealth. So have a great afternoon.
And with that session, Evelyn, oh my gosh, in the proposed physician fee schedule, there is some crazy stuff with mental telehealth services, and crazy in the sense, that's probably not a good word to use. Crazy in the sense that it's extremely technical, hyper detailed coding and billing requirements, but expanded telehealth coverage that's coming up in 2022. So I'll make sure I address that in next week's session as well.
Sounds super timely. Thank you.